Hello and welcome. My name is Jamie Connerman-Cease, and I am a clinical ethics assistant professor here at the Center for Bioethics at the University of Minnesota. Thank you so much for joining our webinar today. Unpacking Bedside Bioethics is a quarterly lecture series where we focus on a range of bioethics topics, but we typically focus on those that impact clinical work. So today, our session is going to focus on suffering. This large concept, we're going to explore it, dive into it, and hopefully break it down. But before we begin, I want to go over some housekeeping information. So if you are part of the mHealth Fairview system, we welcome you to engage with us in clinical ethics consultation work. The Center for Bioethics offers clinical ethics consultation for the whole system. So if you are part of that, reach out to us on our secure messaging platform, Vocera, through the Clinical Ethics Consultation Service. We're available 24/7 if you have any ethics concerns. So as far as housekeeping goes for this webinar, please use the Q&A function to ask questions or let our center's staff know if there's any technical difficulties. We will be recording this webinar and slides will be available afterwards. And so also if you need captioning, these captions are enabled so you can view captions by clicking captions and show captions at the bottom of your screen. And finally, we take evaluation really seriously. We really value your perspective on this webinar. So there's 3 ways to access our evaluation after this webinar is over. There's a pop-up. There's also, it's linked in the presentation details document, which is available in the chat. And you'll receive an email after the event with a link to complete that evaluation. So if you have any questions, again, please use that Q&A function and let us know how things are going. Also, if you're seeking credit for this particular session, we do offer CEUs. Complete the form linked in the presentation's details document for that. We offer IPE credit if you are a University of Minnesota student who is currently actively enrolled in a health professions program. We have a 15-minute discussion after today's session, so find that linked in the chat, and you also need to complete a reflection form. If you are a biomedical engineering student, we also receive credit. You can find that in the assignment course or the assignment version of Canvas, and you have to confirm your attendance to be able to receive that credit. Also, if you have any questions, please follow up with us via our email. All right, so now I want to introduce our speaker today. We're so excited. Today we have Dr. Tyler Tate, who is an associate professor of pediatrics at Stanford University, where he works as a pediatrician doing palliative care. He also is a writer, and he also performs ethics consultation, and is very actively involved in our bioethics world as well. He practices pediatric palliative care and is a clinical ethicist at the Lucille Packard Children's Hospital at Stanford. He's also in the core faculty of the Stanford Center for Biomedical Ethics. Tyler is currently a Greenwall faculty scholar on suffering, and he will be sharing his research with us today from that particular exploration. So Tyler, I want to hand it over to you. We're so excited you're here, and take it away.
Well, thanks for having me. It's a huge honor to be here, and I'm going to start sharing my slides. All right, this is going to be a bit of a tour de force, so just buckle up. So today the title of my talk is To Suffer What We Can't Evade. What is medicine's role in responding to suffering? I received funding from the Greenwell Foundation as a Greenwell faculty scholar through 2027. And our objectives today, I changed one, the second one. So we're going to review some theories of suffering. We're going to examine a novel theory that I am sort of developing, which I'm not sure what it's going to be exactly called, gap theory, prism theory. We'll let you decide. And we're going to analyze briefly the ethics of suffering, although that is really not going to be the major point of this talk. It'll be more trying to get a grip on what the concept is so that we can actually do good ethics. And we will consider humanistic ways of engaging suffering and kind of think about the question, can suffering be healed? I'm a palliative care doctor, so this is a question I'm asking all the time. All right, so to start, why suffering? Well, mainly because it's really important to this thing called medicine. It is a primary goal of medicine. And this has been the case for a long time. William Osler, one of the founders of modern medicine, created the residency program as we know it, said that to prevent disease, to relieve suffering, to heal the sick. This is our work. It's one of the four goals of medicine, per Daniel Callahan, the founder of one of the founders of the Hastings Center report, or the Hastings Center. And there is a crisis of suffering due to increasing worldwide burden of chronic diseases that must be conquered. For my field, palliative care, it's really the core concept. Palliative care aims to improve patient quality of life through the prevention and relief of suffering, whether physical, psychosocial, or spiritual. And for those of us who practice clinical medicine, whether that's in ethics or in clinical care, we know that prolonged exposure to suffering can lead to problems in our own selves, our own souls. It can result in hypoengagement to clinicians who treat suffering can develop apathy and feelings of helplessness. I know I have felt that myself. I just was on service last week. I just got off service yesterday. I'm on ethics service this week, and I have felt that feeling multiple times this past week. So, what about ethics? This is an ethics talk. So, let's talk about suffering and ethics, medical ethics. And I'm going to talk about a lot of people. I have a lot of references in this PowerPoint presentation for those. Hopefully, this will generate some increased interest in the topic and more scholarship. Um, so last year, Brent Kios at University of Utah and others published a qualitative analysis where they looked at how suffering is used in adult ICUs, and they found that it's used frequently. Clinicians contributed more than half of the initial uses, and that in describing the suffering of persons, about 60% were related to a decision, and 42% of decision relevant uses accompanied a proposal to limit treatment. Interestingly, people oftentimes ask me, why in the God's name are you so interested in suffering? What a depressing topic. And I'll tell you why. Well, there's like a long story and a short story, and the long story goes back to when I was a kid, just trying to grapple with suffering in the world. But the shorter story, the one relevant to this group, more relevant, is that when I was a pediatric resident at the University of Washington, and I was on my neonatal ICU rotation as an intern, I realized this sort of bizarre thing that was happening, which is I would be on for 4 weeks, for a month. And every week, though, we would have a new attending physician, neonatologist. And I'd be caring for these babies who maybe they were premature and had had big hypoxic ischemic injuries, so their brains didn't work very well, or they had a genetic diagnosis like trisomy 13 or trisomy 18. They had a breathing tube. And what I've realized was that depending on what attending was on, the narrative around how bad things were, how much suffering this child was going through changed dramatically. So one attending would come on and it was no everything was about how much suffering this kid was going through, how horrible things were, how with every breath of suffering came the sort of implication that we should redirect, that we should remove the breathing tube, we should let this child die a natural death to relieve them of their suffering. And then a week, and the parents were on this roller coaster, like, oh my gosh, things are so bad. Or maybe they were like kind of trying to resist that. And then a new attending would come on, and their narrative would be, oh my goodness, are you kidding me? I've taken care of lots of kids like this. And, my neighbors have a child who's 7 years old with this diagnosis, and they're doing great. Here's a picture of them. Here's the calendar with all of, every month is a different child with this diagnosis. They're not suffering. And what are you even talking about? Like, they're certainly not suffering right now. I'm sedating them. And so these families would be on this whiplash back and forth. They're suffering, they're not. They're suffering, they're not. And this was bad care. And it also oftentimes led to decisions that I felt were somewhat suspect and that were actually not linked to the patient in front of me that I was caring for every week, but rather to some other grander narrative or set of biases or perspectives. So I thought this is a problem that needs to be solved. And everyone is acting as if this is just such a clear problem, but it's really not. So continuing on, What I was experiencing when I was a resident is certainly what we see occurring when we go to the literature. As Dr. Kios's study just showed in the adult world, the same happens in pediatrics. So this is a well-known study by Dr. Fortney, who looked at bereaved parents whose children had died in neonatal ICUs. And what she and her group found was that perceptions of infant suffering or the potential for suffering influence changes in treatment. Oops. And here's a quote from a father. I would say she suffered. We let her go because we didn't want to see her struggle just for us to have her here. We dealt with the heartache so she wouldn't have to suffer. Okay, and things get even more confusing and potentially contentious. What about medical aid in dying? Many of you on this call probably know that suffering is a primary justification for medical aid in dying. Well, what's interesting when you look at the policies that describe when medical aid in dying is legal or ethical, you find two usages of suffering that are actually pretty distinct. And we're going to get into this in more depth later in the talk. But for instance, in the United States, suffering is generally viewed as something that indicates something else bad is happening. So, two doctors affirm suffering from a terminal disease, if possibly suffering from a psychological or psychiatric disorder causing these impaired judgments. The patient is not suffering from a psychiatric or psychological disorder causing impaired judgment. This is applicable to a selection of states. And I practiced in Washington. I did my residency in Washington. I spent 6 years practicing in Oregon, and I practice in California. So these are this is the language of the state's legislation that I work in. Now, when we move from the US to Canada, there's an interesting switch in the way that suffering is used. So in Bill C-14, which carved out medical aid in dying as something that is legal, they state that recognizing the autonomy of persons who have a grievous and irremediable, am I pronouncing that right? Medical condition that causes them enduring intolerable suffering to seek medical assistance in dying. So here, suffering is viewed more as a noun. It's something contained within itself that doesn't refer to some other thing. It just is present or it's not. And as we'll briefly touch on, how you analyze ethically suffering or what it implies or what our obligations toward it are different depending on how we think about it. And this is just to note that this matters. In pediatrics, many of you may have heard of something called the Groningen Protocol, a very famous, or I should say more infamous, protocol from the Netherlands that basically lays out the criteria for when neonatal euthanasia is ethical and will not be able to be litigated, will not be legally problematic. And one of the criteria for this protocol is suffering. And interestingly, Dr. Verhagen describes suffering as a subjective feeling that cannot be measured objectively, whether in adults or in infants, but we accept that adults can indicate when their suffering is unbearable. Infants cannot express their feelings through speech, but they do so through different types of crying movements and reactions to feeding. So clearly here, suffering is viewed as something that is so bad, so problematic that it is better to remove the vessel of suffering than have it be present. And it's this is what in some of my writings I've described in pediatrics as suffering either operates generally in practice either as a mirage, so that if you don't have consciousness, you can't suffer. So we're not going to, there is no suffering here, or a scandal. Suffering is so problematic, so egregious, such a blight that we have to get rid of it. We have to do something. Notably, with the advent of palliative care over the last 20 years, the Groningen Protocol is hardly ever used in the Netherlands, but it still does exist there. And this, one of my friends sent me this just yesterday, and I just threw it in last night because it just shows how current and how relevant the question of suffering is. So the columnist David French, the New York Times columnist, just wrote a paper called What It Really Means to Choose Life. He is distressed at the medical aid in dying policies in Canada and some of the prenatal testing and family planning practices that are going on in the biotech hub here in the Bay Area where I live, and talks about how a decent society should do all it reasonably can to reduce human suffering. Goes on that extinguishing the lives of those who suffer, the lives of those we believe might suffer, is bad, and then talks about this transition from understanding that suffering is an inevitable part of the human condition, or one that rallies people together, to being someone's fault. I'm not endorsing this view or critiquing it, but rather this is just to show how important this question is, and how relevant it is to medical ethics today. And to conclude this section on kind of mobilizing support for why we need to think about this, is Erica Salter's paper called The New Futility, where she essentially worries that suffering has become the new futility in medical ethics, and says that claims of suffering can consciously or unconsciously smuggle value judgments into ethical deliberations that appear or try to take themselves to be value neutral. And she says that the term suffering has great rhetorical power. It's far too easy to be swept up into the mystical gestalt, I love that line, of suffering without realizing that what is actually being referred to is much more opaque than we thought. This is exactly what I experience in my clinical practice and my ethics consultation work. And I commend her for bringing light to this. And for those of you in bioethics, you know that the last few decades, the futility decades, have largely been, a lot of time and energy has been dedicated to parsing apart the types of futility and then work out the ethical responses to types of futility. And I think the same work needs to be done for suffering. That's part of what I'm trying to do here. Okay. All right. So what the heck is suffering then? Um, I'm going to ask everyone attending this webinar to reflect on it for a minute. And while doing so, I'm going to take us through a series of pieces of art that demonstrate what I would view as different types of suffering. Some of these pieces of art are extremely intense and depict suffering in some of its worst situations. So just sort of prepare your hearts and minds for that. And I'll just mention what each painting is and who the painter was. So this is Old Man Suffering by Van Gogh. And we'll just dwell for 5 seconds on each piece. This is a painting called Hambre, or Hungry, by the Ecuadorian painter Oswaldo Guayasamín. This is a painting called The Captive Slave by John Simpson. This is a lithograph created by the artist Keith Kolovitz called The Widow, which depicts a woman who has become a widow in after the wake of World War I, was also pregnant. This is the well-known Blue Nude by Pablo Picasso. Without Hope by Frida Kahlo, who underwent numerous forms of illness in her own life. This is The Hunted Slaves by Richard Ansdell, painted in 1862. And lastly, a painting called In the Camp by Felix Nussbaum, a Jewish painter who actually died in a concentration camp. I'm 99% sure that did occur. All right. So after walking through those graphic, literally depictions of suffering, a lot of things probably came to mind: forms of oppression, abandonment, isolation, devastation. And one thing that I believe these paintings depict is this sense of deep threat or injury or insult to selfhood, to identity, to be able to be the person that you are. That is exactly the thing, the idea, the concept that Eric Cassell, who is by far the most famous theorist in medicine and biomedical ethics on suffering, described as suffering in its totality. So, um, Eric Cassell was a physician, an internist, an adult internist who worked for many years in the Upper East Side of New York and wrote a series, was a prolific writer, and advanced really the first theory of suffering uh, that a comprehensive theory of suffering, certainly that medicine and bioethics had ever seen. The more you study him, the more you realized actually that it is really one of the few theories of suffering in the English language, at least for the last several hundred years. So it's really important to understand Cassell's work and to recognize that his work has essentially become paradigmatic for medicine. What I'm going to argue today, and I believe strongly is the case, is that Eric Cassell is wrong. And we should not be using his theory of suffering as the sum total of suffering in our fields. And at least some part of the rest of this talk is going to be hopefully convincing you of why that is the case. Now, Cassell is brilliant, and he picks up on many things that are certainly a part of suffering. He says that suffering is the severe distress induced by the loss of integrity, intactness, cohesiveness, or wholeness of the person, or by a threat that the person believes will result in the dissolution of his or her integrity. In order to suffer, a person must be aware of the past and the future and be able to assign meaning. This is why he says animals may suffer, but very young infants not suffer. They can have pain, even terrible pain, but not suffer. And for Cassell, suffering is a monolith. Suffering is suffering, he said. There are not different causes of, there may be different causes of suffering, but there's not different kinds. Suffering is suffering. What I'm going to argue is the exact opposite, that suffering is nothing but a series of types. And we'll get to that in a second. There is so much here. I could give an hour talk, I could give a 2 hour talk just on this slide. But two papers that sort of are must reads, I think, when you think about the different theories of suffering, because there are other theories, is Charlotte Duffy's talk, Pathologizing Pathos, and Brent Keogh's work. He's written a ton of great stuff, and this Three Kinds of Suffering is a frequently cited and important paper. Okay. So, what is wrong with Cassell? I'm not going to go through every point, but I'm just going to go back to the empirical, the empirical world that we live in. So, in Brent's study looking at how suffering is discussed in the ICU, what they found is that the target terms had a variety of implicit meanings, including poor prognosis, reduced functioning, pain, discomfort, low quality of life, and emotional distress. And critically, suffering was frequently attributed to persons who were unconscious. Okay, that goes, nothing could be more contrary to Cassell's theory. Definitionally, suffering is something that occurs is a state of conscious awareness. I love this is a pic that Brent sent me. I'm sure, Brent, if you're listening, your dog is much bigger. We need to update this. But in this study, they looked at, there's just some clips, and I think for those of you who do clinical work, this is going to be very familiar. This kind of like ongoing negotiation and kind of culmination of an analysis of what's going on for a patient that sort of erupts into, well, they must be suffering even if they're not feeling anything. So when discussing a severely ill, intubated, and sedated patient that should get dialysis, a family member suggests they might be suffering. The clinician says, I think we would just be treating his numbers rather than making him better and just kind of keeping him going even though he's not really there. Family says, suffering more? Clinician responds, yes. Or another example, patient sedated and intubated. So not having probably conscious experience or many feelings. The clinician expresses near certainty that they're suffering. Yeah, it's been hard. I mean, even just throughout today, just trying to figure out how to keep him comfortable. We still have to keep him alive, basically. All the medications we're giving him to try and keep him comfortable, make his heart rate go up, go lower, make his blood pressure go lower, so he won't. Well, there's a lot of limitations in what we've been able to try to do to try to keep him comfortable. But I feel bad because he is suffering. He is suffering. I can see it. So what is being seen here? This is also found in pediatrics. So this is a well-known study by Betsy Bloom out of Boston Children's, where they also spoke with grieved parents who've had a child die from cardiac disease. And what they found, interestingly, they say, perceived degree of suffering in this study is not associated with child consciousness, contrary to what they expected. And then they go down and they say these completely sedated children who were completely sedated may have The parents of children who were completely sedated may have perceived suffering in the sense that the child was unable to express any feelings or emotions, or it may have reflected the parents' own sense of suffering in being unable to communicate with their child. So there's a lot going on here. And we're kind of, where are we left? I think right now we're left with the words of Stanley Hauerwas, the well-known Duke theologian, who said, after trying to read all I could get my hands on concerning the meaning of suffering, I am convinced that never has there been a word used with such an uncritical assumption that everyone knows what they are talking about. And that's problematic, isn't it? Because the word does a ton of work for us in medicine and bioethics. All right. Now we sort of are entering into part two of this talk, where I begin advancing my own theory about what I think suffering is. Okay, so when you study the history of suffering, you actually find that the Casselian idea that suffering is some kind of deep impingement onto the self is a pretty modern usage of the word in isolation. That way of thinking about suffering has always been here or there when people talk about suffering, but it's only one of many usages. So, what does the word mean? And we have to remember the word suffering translates from the Latin, which means to undergo or bear, to endure, to carry. For you suffer fools gladly because that ye yourselves are wise. You experience fools, you bear with them, you encounter them, you hang out with them. Um, and this is related to the Latin root pati, which means to endure or undergo or experience. And this is the root for the word passive. So in antiquity, to suffer actually meant to have emotions bear upon you and potentially knock you off kilter from what reason would dictate, right? So this idea of an emotion overwhelming us so that we can't act in accordance to reason. That is what the sense of passion really is. And these are the roots of the word compassion and, in fact, patient. Patient literally means the one who suffers. So there really is no word that seems more important for us to know what it is, since that, in some ways, our whole worlds and fields are oriented around the patient, right? This is why, of course, the Passion of the Christ meant the thing that the Christ underwent, all of that suffering. Okay, so that's how it's used in antiquity. There's also a Greek cognate, which is the word pathos. Okay, so so suffering in antiquity meant much more to undergo something bad. It turns out that most of the time when we look to how suffering is actually used in the world, it's used to represent and describe a whole host of ways that things can simply go bad. And it need not have anything to do with some complex, unique, and almost precious sense of self or identity. Rather, look at all these newspaper clippings that my former mentor Bob Perlman at the University of Washington put together. Thousands of middle-aged women suffering eating disorders in secret. Marine animals suffering, former staffers say. The stock funds are suffering. Teenage girls suffering from allergies. All of Syria's children are suffering from toxic stress. The whole continent of Africa is still suffering despite global drop in death rates. And there's more. Millions are still suffering from the Vietnam War, the human suffering caused by China's one child policy. North Korea is suffering serious drought. Why are more American teenagers than ever suffering from severe anxiety? Endometriosis, the hidden suffering of millions, and villages in Ukraine still suffering the legacy of Chernobyl more than 30 years on. So over and over, we see that suffering is easily applied to all of these occurrences where people, communities, countries are undergoing some bad thing. They're in some way knocked off the mark of how we intuitively feel and believe they ought to be. They ought to be going. They're going well. They're not able to go well. That is their suffering. So this is from a paper that I published 5 years ago, which is sort of a more inchoate version of what I've come to believe is the case. that I'm going to read. And this is really an attempt to debunk the feeling theory of suffering, or the idea that suffering has to be something that we're feeling. And many theorists claim that suffering is a feeling, that one can in fact feel suffering, but I think this is a mistake. One cannot feel suffering any more than one can feel sitting or feel eating. Consider sitting. People or animals are sitting when their legs are bent or not, their rumps are on the ground, a chair, a stool, they're neither standing nor lying down, so forth. There's, of course, a feeling to sitting, or put more accurately, I think there can be a whole host of sensations: pressure on my rear, emotions, relief after a hard day, joy after a marathon, I run one, so nice to sit down, that may accompany the state of sitting. However, these diverse feelings are neither necessary nor sufficient. One can fall asleep but still be sitting if other criteria are fulfilled. The same is true of eating. Eating can evoke myriad sensations, but I can also presumably be accomplished sensation free, as when I zone out but regrettably devour a bag of potato chips, as I may or may not have done last night when I was preparing for this talk. Suffering is not dissimilar to these experiences. It's not a tangible sensation to be felt, but rather a broader disposition in which one feels or can feel. So, as I have reflected on this, what I believe to be correct intuition over the past 5 years, my view has developed, and I would hopefully is more nuanced. So, I've come to see suffering as something very similar to justice, or perhaps injustice. Suffering is a description of something real. It's generally a judgment or an evaluation, and it's intimately related to flourishing. It almost would seem to be, in many cases, just the absence of flourishing. But things are more complicated, because you'll quickly be able to think of counterexamples if we don't do a little more work. So the question of what is human being, human nature, is important to the question, what is human suffering? We cannot escape the question of what is human being or human nature here. And any views that try to actually implicitly have their own built-in theory of human nature, I promise, such as including Cassell's. So my view is actually is a lot more similar to a Buddhist view. So the Four Noble Truths of Buddhism, dukkha, which is translated generally in English to suffering, or unsatisfactoriness, but mostly suffering. It's really a linchpin of Buddhist thought. And the first noble truth, the Buddha lays out that birth is suffering, sickness is suffering, old age is suffering, death is suffering, pain, grief, sorrow, lamentation, despair, suffering. Association with what is unpleasant is suffering, disassociation from what is pleasant is suffering. Not to get what one wants. In short, the five factors or aggregates of individuality, which are like the five dimensions of humanness. That's one way that I read that. I've read it. Subject to clinging or suffering. Um, and so it's this sense in Buddhism that change is inevitable. Things are always changing. So we're always losing something constantly. And the extent to which we cling to those previous aspects of self, technically not self, because in Buddhism there is no self, but to the world is our suffering. But in Buddhism, what is key is that suffering is a normal part of the human life cycle, which is quite distinct from Cassell's view, which is that suffering is something sort of specific or extraordinary in some sense. There are other kind of precursors to the view that I'm ultimately landing on, and that you find this in Buddhism to an extent, and you also find it in the work of many of the Christian thinkers, such as Thomas Aquinas, who existed kind of in the pre-modern world. Aquinas says that what produces sorrow is our recognition of the gap between the condition we desire to be in union with all other goods, insofar as they complete our natures, and the condition in which we actually find ourselves, described by terms like fragmentation or alienation. Now, you may be thinking, wow, this is too theoretical. Where is this link to the real world of clinical practice or ethics? I promise you that actually you must have this kind of broader theory, and what it will ultimately do is help make sense of the suffering claims that we're hearing in daily practice. And what I think we'll see is that we dissolve this kind of whack-a-mole feeling to suffering, which is that we can never quite pin it down what it is. So this has led me to what I believe to be an accurate sort of summary of what suffering is and developing a theory of suffering. So um, ultimately, suffering is to undergo something very bad. But bad ends up being culturally determined, at least in part. And so you have to do more work to really get to the bottom of what is going on when we're talking about suffering. And so I believe that suffering is the experience of a gap between how things are and how things ought to be. The word experience here, and if you read my objectives, this has been a shift, a realization over the past 6 months when I submitted my objectives, that I don't think there are two kinds of suffering. I think that there is many kinds of suffering, in fact, way more than two, but they're linked in this sort of family resemblance by the fact that they all are some form of judgment of a gap between how things are and how things ought to be. And the first time I really reflected on this was listening to the palliative care doctor B.J. Miller in this Netflix documentary called Endgame, which I recommend. Talks about suffering like this, and he's very influenced by Buddhism. Okay, so where does that get us? It gets us toward a taxonomy of suffering, and this is what I'm working on right now, and haven't published this, but we'll be hopefully publishing it soon. So I believe that suffering for human beings exists within a variety of dimensions, the dimensions being the different dimensions of what human beings are up to, what we do. And these are linked to the different ways that human beings flourish. Human beings, unlike groves of trees or a collection of pine trees, do a lot more things that involve, and well, I should not say do a lot more things, but have a lot more complex and enigmatic ways in which they can flourish and therefore suffer. And I think that there are sort of a spectrum of ways that there's a spectrum of the extent to which these forms of suffering are in some sense up for grabs culturally, meaning that they're culturally determined and change and shift across cultures and time for human beings, versus ones that are much more rooted in the embodied animal natures of human beings, such as physical suffering. And so, what this means is that in clinical work and when doing theorizing for suffering, we need to reject the idea and that sense that suffering is something is a distinct clinical entity. Rather, suffering is just a way to describe when things are going very poorly for some living being or collection of things that when we look at them and understand them, we see them as going towards some end. So that's why the stock market can suffer, because we have a sense for how the stock market ought to go. And human beings themselves, or personally myself, can suffer in a whole variety of ways, depending on which aspect of my flourishing is being referenced. And so suffering must be put through a prism. When I'm doing goals of care conversations now, I don't let folks talk about suffering, capital S suffering, as if it were some distinct clinical entity, because it is not. Rather, suffering has to go through the prism and be refracted out into a variety of types of suffering, as the previous slide depicted. Existential suffering, which is, I believe, salience suffering and a major and critical part of suffering. Social suffering, physical suffering, psychological suffering. There's a whole host of types of suffering, and there's different responses that each type deserve and warrant. And by disciplining ourselves not to let set capital S suffering, the reified kind of version of suffering, exist, we find that suffering becomes more tractable and more understandable. Um, and this behind this sits a theory, a theory of humans, and just I almost didn't include this slide, but I think it's important, just to kind of in a sense of showing the work. Hubert Dreyfus and Charles Taylor have a book called Retrieving Realism, and where they talk about something that many people over many years and many disciplines have recognized, which is that there's this interwovenness of human beings being these animals, much like non-human animals, and also have these things, human meanings, life meanings, and that they're interwoven into each other. But to actually describe the thing that is language utilizing human beings is you must actually understand both of these interweaving dimensions. And this theory of suffering tracks with, I believe, what humans are. So this is for human beings suffering is going to be different than other kinds of organisms suffering. So what are the implications of this? Suffering runs along the fault lines or joints of human being, and there's no such thing as unpredicated suffering. So, and this, once you really realize this, for me, it has solved so many problems. For instance, in the literature, there are all these debates. Well, this is suffering, so then like this can't be, or this is suffering, and so clearly this is a paradigm case of suffering. So then this other theory can't be correct. For instance, running a marathon. Cassell has said that running a marathon is certainly not suffering, and anyone who says it is wrong and kind of silly. Because for Cassell, my central purposes are, as long as those are intact, I'm not suffering. Now that's absurd. After running a marathon, I certainly suffered. I know I did, and it makes sense with how we talk about the experience of huge, ridiculous physical feats. But it's both are really true because what we're doing is allowing ourselves not to put suffering through the prism. So I suffered physically, but I did not suffer existentially. And it's just as simple as that. And that tracks with how the word suffering has been used since really back into the Latin and Greek. And it's only until quite recently, and there's a Dr. Duffy, Charlotte Duffy, does a great genealogy of how we got to this weird place, is that that's fine. There's different, we can suffer in some ways, but not be suffering in other ways. And that just is what's going on with suffering. So when a parent whose child has some devastating diagnosis and is nearing the end of their life in an ICU, but is totally sedated. And so doctors who are very, scientifically minded and think that all important and interesting answers can be solved by a clinical trial, say, of course they're not suffering. They have no conscious experience. They're parroting a kind of Cassellian theory. And a parent who says, no, of course they're suffering. Look at them. This is terrible. A variety of things can be going on. And I think this prism analogy really helps us work through that. It gives us traction for our language. And we can say, well, maybe what they're saying is this child is spiritually suffering because they've been divorced from their creator in some important way and the things that they were created to do. And we can actually work through that. And you might say, oh, is this up for grabs then? I would say, no, of course not. This is what we do with justice. We advance a theory, we try to capture as many examples as we can, and then through language and dialectic, we work to get to the bottom of things. That is literally what we do in palliative care. So let's do it. And let's have this sort of way of conceptualizing suffering, which is very useful in that regard. So what about the ethics? I'm barely going to talk about the ethics. I've got 2 minutes. Really, the ethics is that suffering, ethically relevant is that suffering is part of the human condition. It's not categorically bad. Disability is not a synonym for suffering because there are a whole bunch of ways that one can suffer. And if you have a serious disability, you might be suffering physically, but not suffering existentially. And that's fine and actually helps us talk to other people who have certain conditions in ways that are meaningful and have traction with the world that we exist in. Can we close the gap? Should we? Are there ways to accompany folks through this experience? I think they are. And in the last 2 minutes, I'm going to talk about ways that we can do that with existential suffering, using suffering as a shorthand, as it is generally. Oh, and this is a book I recommend by James Davies that sort of I've drawn somewhat from. I don't recommend everything in it, but I think on the whole, it's a good book that talks about how a better way to think about suffering. So this is I'm going to fly through this. This is a study that I did with Elizabeth Stein and Robert Perlman, where we tried to capture the language of suffering. And we looked to good writers who had written pathographies, descriptions of their own illness experience. And we did a thematic analysis and ultimately found that the way that suffering was talked about by these patients, patient writers, was through a bunch of metaphors like brokenness, diminishment, disorientation, drowning. All of these things you can see indicate some kind of gap between how things are and how things ought to be. When you're drowning insofar as you're not on land being able to breathe air. There's a gap here that is going on. This also equips us to have a language to do the work that we do in pain, where we use metaphors to communicate about pain, because it helps to some extent close the gap between your inner world and my inner world. And so this is to counter what um, some have said about suffering, which it is just silence. Um, and this is a paper by a group out of Harvard, led by Tyler Vanderweel, that advocates for screening approaches to suffering so that you can then mobilize therapeutic encounters. And I'm going to conclude with this quote that I think Arthur Kleinman, the iconic medical sociologist and psychiatrist from Harvard, in his 1988 book, The Illness Narratives, is really getting at a form of existential suffering, although perhaps other types as well. And he says, we can envision in chronic illness and its therapy a symbolic bridge that connects body, self, and society. This network connects physiologic processes, meanings, and relationships so that our social world is linked to our inner experience. Here we are privileged to discover powers within us and between us that can either amplify suffering and disability or dampen symptoms and therefore contribute to care. And it's possible to talk with patients. This is what this whole gap and prism are helping equip us to do. Even those who are most distressed about the actual experience of illness, and that witnessing and helping to order that experience can be of therapeutic value. And that's what I use these metaphors that we gained from this empirical study looking at pathographies to do. We help order patients' experience, and that itself is a form of healing. All right, that was a tour de force, and sorry that it was so quick. And now we do have 14 minutes for questions.
Fantastic, Tyler. I mean, the Q&A session, like, it's just filled with very thoughtful questions. So I'm going to focus on the questions that we have live today because they really interact with your presentation. I want to start with a question by Andrew, I think, or Andrew. What How does your definition of suffering interact with Dame Cicely Saunders' view as it influenced hospice care, right? So you're a palliative care physician. Hospice care is really influenced and shaped you. But how does this view of suffering that you've laid out here interact with that really foundational view that Dame Saunders put forward in hospice care and in the foundational sort of revolution that we had in medicine back in the 60s?
Yeah, I think it provides a theoretical backdrop against which her work on total pain and total suffering makes sense. And I still think that there is a sense where Saunders' work is overly subjective, in that I think that she as all of us, was a result of a time where subjectivity and the carving out of a sick person's subjectivity was critical. It was a critical endeavor for the dying person to have their inner life sort of platformed. And so what she really did was try to understand the different dimensions of one's inner life. And so I think that I view my theory as highly compatible with that, and even sort of helping explicate the theory of, or kind of what's going on under her work, and what I think, and totally in line with her call for different kinds of clinicians for different types of suffering. And so I think this actually just says, yeah, let's actually qualify what is being addressed here. This is not suffering capital S, but this is some form of spiritual suffering that is going on. And who the appropriate person for that is a separate question. But I think it coincides with her work, and I have obviously read a ton of her work, and so have been influenced by it.
Right. Let's dive into that taxonomy a little bit more, right? Because that's what you're laying out here. You're taking sort of her call to say, let's attend to suffering, and you're like, let's go, let's dive in, right? So Dana asks a question in your taxonomy of suffering, how do you really differentiate between all these different aspects, existential, spiritual, psychological, social, right? How are we exploring the differences in these things? How do we make sure that we're making a difference if we're actually making a taxonomy?
Yeah, it's a great question. So in the background of that taxonomy is the work of Amartya Sen and Martha Nussbaum on the capabilities approach. So, which is Aristotelian in its sort of foundations, which is to say that, so in her book, Creating Capabilities, Martha Nussbaum, social theorist, lays out these sort of 10 domains that human beings flourish in. And these are things like education and friendship and these sort of kind of crucial areas. I'm also really influenced by the work of Simone Weil here in her book, The Need for Roots, where she says like, they're just things that human beings need to live their best lives. And it's actually not it's not totally up for grabs. There we can reason our way into these certain kinds of conclusions. And so for me, um, filling out that taxonomy is the work to be done. I'm not saying I haven't done it yet. It requires argumentation and it requires really looking into some empirical science, of human psychology, and, politics to think about where have human beings lived their best lives and in what ways. But I think the tricky thing to always remember is that um, these do I am not a I'm not an essentialist in that I don't I don't think that we're going to be able to solve this problem and then put it to bed forever. I think that many of these things will change over time as human culture morphs and changes. And so um, despite the fact I draw a lot from an Aristotelian way of thinking about humans, I'm also kind of at the bottom. Also, I'm very influenced by pragmatism. That I think this is why my method is an ordinary language method, drawing from Wittgenstein. Like you go out, you look at these language games, you see how people are using their words, and you can't completely flout language. I believe, though, that language is linked to the world. We can't just say whatever we want and it be true, actually, there are some boundaries and limitations. And that's what a glorious miracle that is, that we can talk about the world and actually come to an understanding with other people. So, all that to say, that's the work. And I would love people to work on that, actually, because I think that there's a lot of different strategies and methodologies that can be deployed to fill in the kind of bubbles using a same kind of like it's the kind of the converse of the capabilities approach. You fill out the circles of human flourishing. Well, this is sort of to fill out the spheres of human suffering in a way.
I think what you're talking about is so important when we're thinking about medicine, right? Because medicine is one way of addressing suffering. And as I think it's Dan Sulmazy who lays out, or, in the past, the reason medicine was created was to address the suffering that arises in anatomy, physiology, and biology, right? But now, especially since the 1980s, we've had this emphasis on the biopsychosocial spiritual model, right? So we're encompassing in medicine more than just biology, anatomy, and physiology. So how do we really think about the medicine's role in addressing suffering in this way as we're expanding and recognizing there are so many other aspects to what suffering really is?
Totally. I think so. This maybe is controversial. I don't know. But I actually think that the idea that medicine is to fix just the biology, and now it's expanded to this larger model is a bit anachronistic, because if you study medicine prior to the 1940s, 1930s, we didn't really have much to offer, actually. And the bulk of a lot of what medicine did was accompaniment. It was making home visits, being with people, listening to their hearts with whatever rudimentary devices we had, coming up with kind of ridiculous therapies. And in the 1800s, it was a battle between the doctors and the chiropractors and the osteopaths, and So it was this kind of everyone was vying for cultural prestige and capital, and ultimately physicians won out because they developed a couple of um, treatments, things, interventions that actually we saw started curing people. But really, the heartbeat of medicine has always been a form of total care in a sense, in the like not totalizing care, like some of like Jeff Bishop and others have critiqued, but like we want to care for people, and people are complicated, and you can't get to the body unless you go through the story. And I think medicine is always been about that actually, and it should be. So I actually think this is just a kind of I think it's the whole biopsychosocial spiritual is more really a recovery movement.
I like that. I like how you say that. You've talked about this a couple times in your talk of you've showed us artwork, you've talked about stories. There's some narrative element here, right? There's a narrative element to exploring suffering that you're rolling out. So what really, as we're thinking about our clinicians at the bedside, what role does exploring narrative play
Mm,
in addressing suffering?
that's a great question. Um, yeah. So we wrote a paper about this. Natalie Lanoka is the first author. I'd recommend it because I we sort of lay out a way of doing this, taking a narrative approach to patient care. It's called "It Starts with a Story," and we published it in Journal of Palliative Medicine. Um, for me, narrative is everything. I actually think that we understand ourselves, we understand others in and through a narrative. And all of our science, all of our norms are narrative and actually floating in the air in a sense. So there's an epistemic assumption in how I think about values and truth. And so I think actually narratives are kind of the first thing that we should focus on in encounters. What is this? What are the pieces of scaffolding that prop up a patient's story, their wishes, their goals, their values? It's a narrative, and it's dynamic, right? And it's oftentimes layered. Like there's what someone says and then what someone does. This idea of revealed preferences. It's really complicated, and so I think. Attending to suffering, doing good medical care, actually kind of starts and finishes in narrative, in a story. And the whole narrative medicine movement out of Columbia and Rita Sharon, I think, is great and a powerful way to sort of think about this. Now, there are always questions of power and um, that we have to be aware of, and disembodiment that over focus on narrative does and can provide us. But at the end of the day, you think about something like a table, which we act as if it is an object that is just isolated on its own. But really, what a table is something we eat on. That's the only reason we know it as a table. But eating is a human practice, and eating changes based on different cultures. And how we tell a story about eating is actually helps define the terms of what a table is and the meanings that eating hold for us. Boom, we're in the world of palliative care here, talking about should we get put in a G tube or not in a elderly, individual who has late stage dementia. So yes, it's all about narrative in some way.
And I think your talk has really pointed out that it's not, you brought up Wittgenstein, you brought up this what is language here. When we're talking about narrative, it's not that we as clinicians or ethicists can manipulate or control the narrative, right? It's not that we are the ones shaping the narrative. So how do we help attend to what narrative is there and then draw out suffering rather than just saying, okay, this is the narrative, this is suffering, right? Coming into a patient's room and saying and laying on top of what is there, what your personal narrative might be of that situation.
Mm, that's a good question. So I think the first thing I would say is even here, I would say we have to discipline ourselves to not just use the capital S suffering. So we have to actually be specific. We have to be concrete. What types of suffering are here now? And how are those? especially the ones that are less directly attached to the body and the physicality of the body, the material aspects of the body. How are they given life in and through the patient's story? And I view it sort of as I mean, this is really complicated at the end of the day, and it's about psychotherapeutic interactions and how we talk to another person. It raises a lot of ethical questions about when to challenge someone's account of a story versus just to let it go. And this has implications for things like medically and dying, like we talked about. And but I think that it is generally the best practice is to sit with someone else's narrative and accompany them through it and in it and be present for their suffering and really because it takes a lot of time to actually understand what the like mini linchpins that make their life a life where they see suffering. And if you don't really go deep and understand it, then you won't be able to in with tact and in a select number of situations potentially challenge that account based upon a way that you see the world in the same way that if you were talking about suffering with someone who was not in overcome by illness you would do, but it's a very very different dynamic and there are really important ethical boundaries that need to be in place. But I do think that this way of viewing suffering allows for that to some small extent. I don't, and that's probably not totally clear. It's like so complicated, like that question.
Yeah. Well, Tyler, thank you so much for this session. We just have, over 50 questions that we are not going to be able to get to, but I've copied them. So hopefully, at least this can provide some sort of motivation as you continue this research. It's such important research. I, on behalf of all of our attendees, want to thank you so much for this webinar. It's been fantastic. As a person working in this field, find your work very essential to my work as well. So thank you so much, Tyler, for joining us today at the Unpacking Bedside Bioethics session.
Well, thank you all so much for having me. It's a huge honor. There's a ton of people whose work I sort of also stand on. I didn't mention, like, Michael Brady and others. So, just dig into this world. There's so many great voices out there working on suffering.
Awesome. All right, to our attendees who are still left, I just want to mention our next Unpacking Bedside Bioethics session is with yours truly. It's me. It's on the ethics of caring for patients without surrogates, what we often can call unrepresented or unbefriended patients. We have more webinars coming up. And also, if you are interested, we teach classes as well. Our upcoming classes this semester are disability ethics, also taught by me. We have a social context of health and illness by Ian Wolfe, who's done a couple of sessions on unpacking for us, and biomedical ethics, that introductory course by Joel Wu. So thank you so much for joining us all today. Tyler, again, thank you. Fantastic. And we hope to see you next time.